you can't have tunnel vision. The conventional thinking may be good for a period of time, but you have to be open-minded to other ideas.
I can't even imagine what you see when you're in there with these visual optics. What's the most interesting thing you've seen in a person's abdomen?
Well, I've seen a lot of interesting things, but I think, from a practical sense, the thing that I found most interesting, and I've thought about how to structure a study to really look at this, is that when we enter the abdomen, I usually use a standard laparoscopic camera to then put in all my ports, and then I can take the regular camera out, and then I put the robotic camera in. So I see the view through a standard 2D view, and then using the robotic camera, which is 3D high definition, looking at the same structures and differentiating what I could see with one over the other. And I frequently will, with more subtle lesions of endometriosis, you won't even see them with a regular 2D camera, whereas with the robotic camera, it's clearly evident when you're looking at it.
So having that as an advantage in surgery is definitely benefiting the women, because you're able to grab things that would futuristically be a problem.
Absolutely. And they're more, and that's one of the things that still is a common misnomer among even surgeons, is that, that endometriosis has a typical appearance. It's true for some lesions. They'll have that powder burn, purple, red, kind of appearance on the surface, but many times they're more atypical. And if you have better optics, you can see those more atypical lesions. And moreover, it's especially important in younger patients, because in younger women, they tend to, while they can still have the classical lesions, many times they're less typical appearing lesions. They're kind of the precursor or earlier stage lesions or implants. And if you don't know what you're looking at, you may say, oh, that looks totally normal.
That's what happened to me when I was in college. I went for a surgery for laparoscopy for menstrual pain. And in the recovery room, he said that he only saw something that was the size of a freckle that was characteristic endometriosis tissue. He said that the rest was covered with an opaque covered fascia-looking substance, so he left that alone. And I was incredibly frustrated, because I knew that the area where he said he saw that opaque fascia was the area where I had the most pain. It was in the front part of my uterus, and I had severe menstrual pain that was causing me to vomit. So just to back up what you're saying, when did those robotics and these advances in the diagnostics come about?
So robotic surgery for gynecology was approved by the FDA back in, I think it was early 2010. And that's pretty much when I began, once it was FDA approved. And then that's when I began my training to learn how to do robotic surgery. Until then, I was just doing conventional straight stick laparoscopy, for the preceding 10 or so years. And at first I was a little resistant to it also, because I was doing something
that was working
fairly well and it was working. But it wasn't until I actually saw the benefits and the superiority of what the equipment offered that changed my mind.
So Dr. Redwine, who passed recently, he created Redwine's theory that was that, hey, endometriosis doesn't just look brown and purple and red.
Right.
It can be green and clear. And the surgeon who did my second laparoscopy in 2005, since I had read about it in like a Christian Northrup, Women's Bodies, Women's Wisdom, Redwine's theory, I felt empowered enough to be able to find a surgeon in 2005 who knew of that. And because there weren't these robot arms to use, and that surgery cleared that. And granted, that was 10 years later, so that tissue had color to it too.
Right.
But he removed all of that, and 2 years later, I had an opportunity to conceive, and I conceived Kira. And then 2 years after that, I conceived Jack with one attempt only. So that surgery was pivotal for me. But the robot arm and the advancements in diagnostics is what led me to the third laparoscopy with you. So, as one of your patients and we're colleagues, we share patients. I refer patients to you and you help them get onto the holistic pathway. How did your practice evolve to include?
What I find very important, and this is something that I've always, the mantra that I've used for myself, and also when I teach medical students and residents and fellows, I've always, said, you can't have tunnel vision. The conventional thinking may be good for a period of time, but you have to be open-minded to other ideas. And David Redwine, who was a friend and a colleague, and he's sorely missed. And he was a pioneer. He really was he paved the way, for more expanded and open-minded view of things. And it's people like him that really help empower others to think outside the box, so to speak. And I think for me, logically, as physicians, we're always, we generally are problem solvers. So you try to figure out why something is happening, what's causing it, and how to remedy it. And when you have a condition like endometriosis, when there's this constellation of symptoms that most people have, as I call it, there's no magic bullet that's going to get rid of all the problems. Surgery is a key element of it. But when people are presenting, and you see the very same patients that I see, they have GI issues, they have bladder issues, they have
painful sex, unexplained infertility, right, recurrent pregnancy loss.
And then they have seemingly other issues like back pain and neck pain and shoulder pain and anxiety and depression. And people tend to treat symptoms and not look at the big picture.
They call that medical gaslighting, right? To just say, oh, it's all in your head.
Correct.
Or if you just manage your stress, you would be fine.
Right. The other thing that I always say is, you have to look at the big picture and the likelihood of something going on. I mean, and if you look at a patient and they're, relatively young and they don't really have any major medical problems, why are they having all these symptoms? The unfortunate modern medical approach is to treat symptoms and not to problem solve. And once you start to look at the different issues that coexist in a lot of these patients, you logically figure out that you need to treat each individual issue part and parcel of the bigger problem. But if you don't address each one, then you kind of hit this point where, yeah, I feel better, and the but is usually, but I still have symptom X and Y. Symptom B, C, and D are gone, but these aren't. And that's frequently what I find in some of my patients who don't want to go for PT or don't want to go for any of these other treatments. They'll feel better in a lot of different areas, but the things that they were resistant at treating are usually the things that they return complaining of. And I'm like, okay, now you need to go beyond your comfort zone and deal with these issues and treat them, and you will feel better. I mean, it's an investment of time and some financial investment also if it involves other therapies and treatments. But I think that the important thing is when people start down a therapeutic pathway and they begin seeing improvement, then they see the light at the end of the tunnel.
They're more likely to go a little bit farther.
So compliance really increases because they're invested in the process. They see the benefits, and they see that there is a way out of the situation that they've been living with for many years. What I call their new normal, which generally isn't normal. But when you start maneuvering and navigating them out of that, that vicious cycle, it's an enlightening and empowering experience because people, they feel like they can take charge of their life again.
Yeah, you're giving so many women here so much more hope and possibility by removing pain, creating potential for future pregnancy, especially as you're not dismissing their emotional component. You're helping them to understand that nutrition does play a role.
Absolutely.
And that's helping their relationship with their body, their sex lives improve. Like there's so much more that you're giving them in doing this operation. Surgeons have kind of a bad rap, but I think in respect to endometriosis surgery, excision surgeons really need to be acknowledged, and we need to find more of them to help patients to know that this is something that they need to do. I wonder, with respect to our evolution and how many women probably have this. Every time I'm on Instagram and I see 1 in 10 women have endo, I feel like there's probably so many more. I feel like 9 out of 10 women probably have endometriosis to some extent. What do you think?
No, I don't know that it's necessarily that prevalent. I think it's probably more prevalent than the 1 in 10, because when you look at some of the other statistics, for example, in the realm of of unexplained infertility, and the statistics are staggering. It's somewhere in the neighborhood of 50+% of women with unexplained infertility. And, for our audience, unexplained infertility are patients who have, the $1 million workup and everything comes back normal, but they're still not getting pregnant.
And they've been trying for 2 years.
Right. Or they get pregnant and they keep miscarrying. Nearly, half or more of those patients have endometriosis. The problem among physicians is that they are locked into this very old school mentality of, well, you don't have the classical symptoms of endometriosis, so you probably don't have it. And that's unfortunately not true. It's not a condition that you can relate typical findings or typical symptoms to, like other medical conditions, like, appendicitis or cholecystitis or anything like that, where you have triads of symptoms and classical findings, et cetera, and so forth. And speaking from over 2 decades of experience, I can tell you that patients are always telling me, like, what's the likelihood you're going to find endometriosis when you operate on me? How much do you think I have? And I can speculate, but I'm constantly surprised. I put the camera in on patients who I think are going to have minimal disease, and they have quite a bit, and vice versa, and everything in between. And in the realm, going back to the unexplained infertility patients, so many of them are like, I don't really have much in the way of symptoms. But what I find in my personal experience, which can't be unusual or individual, is that when you sit, and this is something else that I'm very keen on, when you actually sit and get a thorough history from people, you find out a lot more information than they were really aware of, or that any other clinician really bothered to find out.
To ask.
And it's because people think that certain symptoms are normal, just because it's come upon them so gradually, and it's kind of part of their life, and they think that having debilitating periods is part of growing up, and they've been told this by hospital nurses and pediatricians and the student health office at college and what have you, and it's not normal, and that's one of the things that I always tell people, like, debilitating periods are not normal. I mean, yeah, you may have some pain, you may need to use a heating pad for a little bit, or take a Tylenol or a Motrin, but it shouldn't be to the point that you can't go to school, you can't go to work, and you're curled up in a ball in your bed or in the corner of the room, or sitting in a hot bathtub for 6 hours. That's just not normal. Mm-hmm. And then when you piece this all together, and they're like, oh, I thought this was normal, I thought that was normal, and like, it's not normal. And the abdominal pain that you have every month, and the motility problems that you have, and food sensitivities, and all this thing that you've been living with since childhood, that's all abnormal. And then you operate on them and you find disease. And then it's eye-opening for the patient. And it's very critical for reproductive endocrinologists also to acknowledge. And many of them do, but there's still some who don't. And they have a philosophy of trying to power through the endometriosis rather than treat it.
Or send them on an IVF with ICSI route, and that's
Right.
going to save everything.
Right.
Or put a month or two of Depo-Lupron into the mix.
A lot of times it requires the mental fortitude to stop, take 2 steps back, and really reevaluate and not keep doing the same thing. Because, the old adage, and if you keep doing the same thing and you expect a different outcome, that's the definition of insanity. And it's true.
Yeah, I try to help my patients focus beyond baby making. Would you like to not have debilitating pain,
Right.
bloating every day, and painful sex?
And I tell people many times, even patients who aren't really interested in fertility per se, it's an issue that will, if you treat it, will open up many avenues, because it will, for some people the critical element is quality of life, and for some people it's fertility. But in reality, yeah, you want to feel better, but down the road you open up the option of childbearing if that's something that you desire.
Mm-hmm. I had to convince my surgeon in 2005 to do surgery. He didn't want to do it because I wasn't in a relationship. I wasn't actively trying to conceive. And I had to say, I miss work, I vomit.
Right.
And I'm almost fainting because the pain is so bad. I learned that my cervix was stenosed, and so blood clots couldn't pass, and that was what was making me faint. I'd have to be taken to his office on day 1 of my cycle. He'd use a Q-tip and pull those blood clots out so that then I could go back to work. That was extreme. And so I said, forget about me trying to make a baby. That's not where I'm at. This is no way for me to live. It's important. So then the other, that's another common fallacy is like, don't treat it until you want to get pregnant, which makes no sense, because it's a progressive condition. Why wouldn't you want to remove disease in its earlier stages, then wait until it's more advanced and deeply infiltrating and causing more, not only symptoms, but it also causes anatomic distortion and destruction of tissue. And as an addendum to that, the old school mentality was, don't treat it when people are young, wait until they're older and of childbearing age. But what we've now discovered is that you can find just as advanced disease in teens and adolescents, and they can be just as affected at 14, 15, or 16 as someone could be at 26 or 36. And I have quite a few patients their mothers are my patients, and because they're more sensitive to the symptoms of endometriosis, they see themselves and their daughters as they're growing up, and they're following the same patterns. They recognize it early, and they're like, I don't want her to suffer the way I did until I was 35 and like unable to conceive, and then all of a sudden I was diagnosed and had surgery, and then thank God was able to conceive and like move on with my life. Why wait another 20 years? Let's treat it now. Mm-hmm. And it makes a lot of sense, because it's also not had all those years to inflict its effect on all other different organ systems, and it's much more difficult to undo a lot of these issues when they've been going on for 10, 15, 20 plus years. Mm-hmm. So why not treat it early on, nip it in the bud, so to speak, mm-hmm. and let someone, take the more pleasant path in life from mm-hmm. an earlier age. And if we're talking about fertility, it would be good to take care of that earlier on for
sure.
the egg reserve.
For sure.
Who can preserve more of their fertility. I think it begs the question of what exactly are we dealing with as the conversation keeps is out there of, it's retrograde menstruation. No, it's undifferentiated embryological tissue. And I'm thinking it's sugar and inflammation from our diets. And then, as we were talking before the interview, microplastics. So like it's a combination of different things, or is it undifferentiated embryological tissue?
Dr. Redwine was really key in theorizing and identifying the etiologic nature of endometriosis. And I think, based on purely on what the literature that's out there in the case reports of endometriosis being found in pretty much every body cavity and organ in the body.
And in men too, right?
Right. It can. There have been several studies looking at men with prostate cancer who are being treated after surgery with stimulating estrogenic effects, which then can trigger that, and which again speaks to the whole embryologic nature of it. And it's these progenitor cells that develop into all the parts of you as a human being. During embryogenesis, there's migration of cells, and there are 3 different cell lines which differentiate into different structures. And we see this in other conditions where you find odd structures developing or being found in people when they're adults, is because of that. Something triggers these cells that are multipotential, that can be developed into
any different organ.
Right. And that would explain why you find it in odd places,
like the lungs.
Right. I mean, I've had patients with lung, diaphragmatic, nasopharyngeal. There's been thyroid, brain. I mean, there's all, you name it. And it's, for the longest time, the only organ that it had not been reported in was the spleen, but now there have been reports of that as well. And the theory why it hadn't been found there is because the spleen is kind of like a filtration system of your body, of your lymphatic system and everything. So the thought was that it was able to, filter or extinguish out those cells.
So these embryological cells that are throughout our body, what is the mechanism here that then creates the inflammatory cascade?
What triggers them to start becoming active is thought to be variable. There was a study out of Italy. They did autopsies on female fetuses that were miscarried, and they found like 9-point-something% of them had already had implants of endo in the abdomen and pelvis. So that kind of creates the genetic linkage, which we know, where, if you have a first-degree relative like mother, grandmother, sister, aunt, even just one, with endometriosis, you have a 7 to 10 times greater risk of having it, which means pretty much 70 to 100% likelihood of you having it. So if you've got any kind of symptoms and that genetic predisposition, that's pretty much a given. So there's definitely a genetic component to it. But as far as what triggers these cells to become active, in some people, it probably starts in utero. In others, it may be after birth, or maybe later in childhood or with puberty. Generally, though, the consensus is that it starts to become active early on. And in the pediatric population, the numbers are pretty significant, where it usually will present in pre-adolescent girls as kind of generalized abdominal pain. And in that subset, 70% end up being diagnosed with endo. And usually the GI symptoms are the most common. And in general, all comers, the most common non-gynecologic symptom that patients have are gastrointestinal, be it bloating, motility issues like constipation, diarrhea. Those are the most common things, or like food sensitivities or presumed allergies. There's also, thoughts or linkage to an autoimmune nature to endometriosis, because there's a higher than average occurrence of coexisting autoimmune conditions in patients who have endometriosis.
Such as?
There are a lot of autoimmune thyroid conditions, different connective tissue diseases. I just actually read a paper which I posted on my Instagram about the higher incidence of celiac disease in patients with endometriosis. So there's definitely something to it. It's too much of a coincidence.
Yeah, the self's attacking itself.
Right, or the inability to regulate and eliminate things that are foreign, or if you want to say not normal, in those individuals.
How do we differentiate endometriosis as it's rapidly dividing cells and contrast that with cancer.
They have looked at that as far as the metabolic activity of cells and mitotic division and mitotic figures. I can't comment exactly because I'm not an oncologist, but there's something, this is my personal opinion, there's some autoregulatory issue in these cases. The other thing that you have to understand, which makes me also kind of suspicious, is just like tumors need to be fed with nutrients and also blood supply. It's the same thing with endometriosis. So it depends on blood supply, and a couple of things that these implants release are growth factors for more blood vessels and more nerves. So they release a nerve growth factor and a vascular growth factor to enrich its blood supply and amplify the nerve fibers feeding it. And that's why they get bigger, and also that's why they get more painful, because if you have 2 nerve fibers feeding something, then all of a sudden you have 20. It's just like, the volume on your stereo. Like, you go from 1 to 8, because of that amplified signal. So there's definitely something to it. And what we find, like when you're doing the surgery, you can see even sometimes it'll be a very small lesion, and you start dissecting it, and it's just very bloody, because and you can see the very plump, congested blood vessels, and a lot of patients with endometriosis have this vascular congestion syndrome, where the entire area looks kind of very, very red, very prominent microvasculature, which usually, like, microvasculature is usually very, very micro, so you don't really see it until you cut into tissue, and then you see a little losing. But here you see these big distended vessels, and that's because they're feeding these lesions. So, getting rid of that, and also getting rid of the source of the nerve impulses that they trigger in the nerves, which then communicate via the peripheral nervous system to your central nervous system, and create this cascade of what we call central sensitization, where you have upregulation of the central nervous system, and not just local pain, but then it becomes more, it kind of blossoms and diffuses to involve other local areas and more distant areas. And that's why people tend to have pain symptoms that are nowhere near their pelvis. But that's what's triggering, all of these different symptoms.
And so it's a case to be made for doing endometriosis excision surgery versus ablation or cauterization.
Correct.
Right?
So you would think that it would be pretty intuitive when you really kind of map it out in your brain. Like if you burn something, what are you doing? You're basically devascularizing tissue, because you're charring it. So you're cutting off the blood supply. So it's not healthy tissue anymore, it's dead tissue. So what happens when tissue dies, it becomes scarred. So now you have scarred tissue, but with endometriosis, because you don't know how deep the lesion is, so now you basically, it may be 2 or 3 millimeters on the surface, but it's 6 or 8 or 10 millimeters deep. So what you've now done is burnt the surface, created this encapsulation with scar tissue at the surface, but you still have the active disease below it. So it goes along its merry way of continuing to do what it was doing. And that's why the majority of patients who have, especially if they have deeper disease, will either feel worse after ablation surgery, or they'll have a short honeymoon period of feeling somewhat better, and then rebound back to where they were or worse than they were.
And that's what the majority of surgeons are trained to do?
Unfortunately, yes. And unfortunately, up until several years ago, in the medical literature in the field of minimally invasive surgery and treating endometriosis was preaching that there is no benefit of excision versus ablation.
That must have been so triggering for you to read.
Extremely. and what it did was, many like-minded surgeons like myself started to really, to publish data negating that. And in very short order, it clearly showed that, especially in non-superficial disease, there was a distinct benefit, and not only benefit from reducing pain scores, but long-term as far as not requiring future surgery, and being more effective at eliminating as many, if not all, of the symptoms in these patients.
I can't tell you how relieved I was when you did my surgery and you were able to confirm that my former implants had not grown back, that
Right.
were on the ovary and on the front of the uterus. That
Right.
was so refreshing. But I know that there's not very many surgeons that do the excision surgery. And so I worry my patients or my audience that's listening to this, they may think, oh, I need to ask my OB if they can take
Right.
this out of me. What should we say about
So
that?
one of the things that I always counsel even my own patients is you always have to be open-minded and never too arrogant to admit that you don't know something. And if you are unable to provide the proper treatment, then you need to direct your patient to look elsewhere where they can find that. And just doing the standard diagnostic laparoscopy, which a lot of people do, and either they do nothing or they'll burn a few lesions, is doing a disservice to the patient. I mean, you shouldn't be looking unless you can treat it. And if you are embarking on treating a condition and you're unfamiliar with and unskilled at treating it properly, then you shouldn't go there. Like, I wouldn't do cancer surgery because I'm not a GYN oncologist. So I know enough that I can probably suspect that someone has condition X or Y, and then be humble enough to refer the patient to the proper physician. And I think what I unfortunately commonly find is people will tell me, oh yeah, I had excision surgery, and then they get me their medical records, and it says it in the operative report. It says excision and ablation surgery, and then you read the details of the operative report, and they take one little biopsy, so they have a specimen to send to pathology, so they have a diagnosis, and then they either cauterize or laser or use some other destructive means to basically burn the remainder of the lesions. And unless it's something very superficial, you're almost guaranteed that you've left disease behind. And getting back to what you were saying, as far as being relieved that certain areas had not come back, that's another misconception. People think they think that recurrence means it's going to come back where it used to be, and the reality is, if you excise a lesion completely, so you've dissected it, you see where the lesion ends and the normal tissue begins, more than likely that's not going to be where it's coming back. I mean, the same pathophysiology that led to lesions forming where they were could theoretically form new ones, but even then, realistically, from my own work and many other people, once someone is an adult, generally whatever was going to kind of sprout is there.
Or those undifferentiated embryological tissues that were there. If you have your surgeon who knows to look for that and has the robot diagnostics, then they can see this is suspicious tissue, I'm going to take it out.
Yeah, I mean, knowing what to look for, whatever developed abnormally is, once you're an adult, so if you're over, for argument's sake, 20 years old, whatever is there is there. It may be at different stages of development. I mean, you may have more advanced lesions and less advanced ones and different appearing lesions. It's just a matter of knowing what you're looking at. And it's not to say that you can't do it laparoscopically. I mean, laparoscopic cameras are also very good. It's just a matter of really knowing what you're looking at. I frequently would have, over the years, medical students or residents in the operating room, and I ask them to look at the screen. I'm like, where do you think the lesions are? And these are people who should know better, or even attending physicians who just have popped in and or I'm operating on their patient and ask them, where do they think it is? And the overwhelming majority would not identify certain areas of being abnormal. And that's why it's key to have your surgery done by someone who's experienced and knowledgeable.
and special training in excision surgery. So I'm curious, what is involved in that? Is it 2 extra years of schooling?
So the standard education that you get as a resident in OBGYN includes, all the, benign gynecologic surgical procedures. Nowadays, with the structure of residency training, there is a fellowship in minimally invasive surgery that began just several years ago. Prior to that, it was all part and parcel of the general residency training. I think part of it is that nowadays the volume of surgery that most residencies expose their residents to is not adequate to really fully train them to do a lot of the different procedures that require expertise and skill. Part of it is because I think with the advent of a lot of specialty fellowship training, it's pulled away those cases from the general residency training. I trained in the era where the only fellowships there were GYN oncology, which is for cancer, reproductive endocrinology, and maternal fetal medicine, which is for high-risk OB. Now you have minimally invasive surgery, you have pelvic reconstructive surgery, so there's more the specialty training. But I think people, my predecessors like Dr. Redwine and C.Y. Liu and people like that, they were on the frontier. I mean, they were in the beginnings of laparoscopic surgery, where they dealt with a lot of craziness because the hospitals and state medical boards were investigating these surgeons because they were saying that laparoscopy was experimental surgery. Mm-hmm. And people had their licenses suspended and hospital privileges suspended because they wanted, they were expected to cut the patient open, like rather than do a minimally invasive. Minimal. So there's always, the beginnings are a very steep uphill battle. I think the problem is in the world of medical training is that we haven't shaken out all this tendency to embrace ablation, because a lot of people still think that that's the way to go.
Is there an argument for ablation that they are defending?
The thing is, ablation is much easier to do because you're not doing any complex dissection, and you're just basically, it's a difference between doing a 15 or 20 minute surgery and doing a 3 or 4 or 5 hour surgery. Because if you start dissecting out a lesion and it's on or invading into a vital structure like bowel or ureter or bladder or blood vessel, nerves, or things, you really need to have the skill and the know-how to do that. And that only comes with experience.
And so in the U.S., is there about 10 endometriosis excision surgeons?
No,
20?
It's probably, at this point, probably somewhere in the neighborhood of 100.
Okay.
It's getting better. Encouraging. It's getting better because there are some good, fellowship training programs where these younger physicians are learning it.
And they want to go in that direction. Hopefully they see that we have a public that's in need of
correct
excision surgery.
Correct. So that it's a process. It's definitely moving faster than it was 10 years ago. But it's not where it needs to be. Mm-hmm. But hopefully with time and more awareness and education, that will change things.
Yeah, I think there's so much, thanks to Instagram, for example, more awareness.
Yeah.
Patients are probably coming into their doctors and asking about it now because they're seeing it all over their feed.
It's both refreshing and surprising that many times the patients will self-refer. They come in and they've done their homework and they're more knowledgeable, it's sad to say, than some of my colleagues.
Oh my gosh. Well, in the fertility space, it's similar, where the women go through IVF enough times that they could be honorary reproductive endocrinologists.
Exactly.
They understand the medications, the procedures.
Exactly. And even in the realm of reproductive endocrinology, there's still some hardcore / or old timer REIs that don't believe that endometriosis is a factor.
Yes.
And
So
and so they do egg retrievals, pushing needles through endometriomas and spilling and tracking endometriosis all over the pelvis and abdomen. One of my favorite patient stories was someone I took care of when I was still practicing in New York, who came to see me. She was in her early 40s and self-referred. And I said, well, how did you find me? And she's like, I was having coffee with a friend of mine last week, and she's a patient of yours, and you operated on her. And I said, how are you doing? And she said, oh, I just had surgery like a couple of months ago. I'm like, for what? And she told her she had endometriosis. And so the woman had no idea what endometriosis was. And so she asked her, like, what is it? What are your symptoms? And she's like, I have pretty much all those same symptoms. And I've been trying to get pregnant for 10 years. And I've been through, I think she went through like over a dozen rounds of IVF. And she pretty much had given up. She was not in a good place. So she took the initiative and came to see me. And this is what I find, very interesting is, and what I was alluding to earlier about listening to the patient. I sat and spoke to her for an hour, and just from her history, I'm like, she has endometriosis. I mean, can I say 100%? No, but I usually tell people, like, if it's so compelling a story, I'm like, I'm 90+% sure that's what it is. And so I did her surgery, and she had endo, and she never came back for her post-op visit. I did her surgery right before Hurricane Sandy. And my staff couldn't get through to her, and like she was like lost to follow-up. Fast forward like a year and a half later, I see her on my schedule one day. I'm like, why does that name sound familiar? I went and looked at her, in the computer at her chart, and I'm like, yeah, I remember her. She never came back for a follow-up. So she came into the office with a stroller and her baby, and I'm like, I looked at her, she looked at me, and I'm like, oh my God. And she's like, I'm not here for a visit. She's like, I just came to see you because I know I fell off the face of the earth because my house was destroyed by the hurricane. I moved in with my in-laws, and it was like 5-6 weeks later, and I was like sick and vomiting. And my husband's like, could you be pregnant? She's like, no, I can't be pregnant.
Kidding? Right.
So she got pregnant. She didn't even have a period after surgery, and she just spontaneously got pregnant and had a baby at like 44.
Wow.
So it's things like that and stories like that. Literally, it brought me to tears.
Yeah. Well, that is a compelling story. This is what Dr. Beck is keeping her spreadsheet, where she's tracking post-excision surgery within 6 months, especially women over 40 who's naturally conceiving. Yeah.
And she's great because she is the more atypical REI, because she will text me or call me like ecstatic, like the patient I sent you, she just called me. She's got a positive pregnancy test. She came in and I did an ultrasound, and she's got like a viable pregnancy, and that's really what it's all about.
Yes, it is. Yes, last week I interviewed Maureen, one of our former patients, and then today Andrea, and both of them conceiving naturally after the surgery.
Right.
I think one thing I want to ask you while I have you here, adenomyosis in the muscle and how treacherous that is for fertility outcomes. What are you doing with those patients?
So adenomyosis is the component of endometriosis that involves the actual myometrium of the uterine muscle. So it's not uncommon in patients who have endo. It's usually not a major factor unless it's very diffuse, because what it is the endometriosis intercalates between the muscle fibers. So if it's not diffuse, it usually may not cause much in the way of added symptoms, or it could maybe be the culprit in like slightly heavier periods. But many women with adenomyosis still get pregnant. If it becomes very diffuse, and usually that will cause the uterus to become very enlarged, and the patients will have like severe endo symptoms and heavy bleeding to the point of like anemia, requiring transfusions, etc. At that point, you can't remove it because it's just involving so much of the uterine muscle. That's the only time where hysterectomy is really appropriate. In some cases where they have what's called an adenomyoma, where it's a discrete structure like a fibroid, it's not unlike a fibroid that's kind of has distinct borders and it's more easily dissectable out of the uterus. The adenomyoma tends to be more amorphous and friable, and it creates a situation where it's much more difficult to remove, and it's also much more difficult to then reconstruct the uterus and suture it closed. But with an adenomyoma, you can, and if it's problematic, you can more readily remove it.
But if it's adenomyosis, then it's kind of marbled in there a little bit. So do you do a hysteroscopy at the same time?
So many of my patients, I do a hysteroscopy as well, usually because there either is something on the ultrasound suspicious for a polyp or a fibroid or a uterine septum, which is another thing that goes with endometriosis, where it's an embryologic developmental abnormality that we see where there's a kind of a little divot or a little cleft at the top of the uterine cavity in the midline. And that's because during the development of the uterus embryologically, it's a fusion defect because the uterus starts out as kind of two lobes, like kind of Mickey Mouse ears that fuse together. In women who have a uterine septum, I think the statistic is 50+% also have endometriosis because they kind of go hand in hand. Mm-hmm. And that's kind of reinforces the whole embryogenic etiology of endometriosis.
Mm-hmm. So if it's an unexplained infertility case and you see that there's adenomyosis when you're in there, then would you throw in a hysteroscopy and then try to help them?
Yeah, I mean, the adenomyosis generally you will not really see much hysteroscopically unless there's some grossly abnormal appearance of the endometrial lining. It's usually other structural issues, like I said before, like the polyps, fibroids, septum, things of that sort, or also just looking at the cavity to see if there's any other structural issues. You can also see the opening to both tubes. And then the other thing that we routinely do is do a chromotubation, which is we inject some dye through the cervix that we can then see laparoscopically that there's dye shooting out of the tubes. So that is like it's the intraoperative version of an HSG, the hysterosalpingogram, that a lot of these patients get to determine tubal patency or that the tubes are open. But the nice thing about doing it in real time when you're doing surgery is I can not only see that that the dye is coming out, but I can see how brisk it is. So if it's just dribbling, usually it's a sign that there's something impeding the flow through the tube. So if one tube it comes shooting out like gangbusters, and the other one is kind of trickling out, or the tube really distends a lot before it even starts to trickle, then you know that there's probably some stenosis or adhesions or scarring inside the tube or at the opening of the tube in the uterus. But it's important to know, that the tubes are functional.
Mm-hmm. Yeah. Well, so much can be learned by being able to look in there.
Right. Mm-hmm.
That's why I'm encouraging my patients. I don't want to give them herbs and cause them a delay or prevent them from finding something that could be game changing.
Yeah, because ultimately, if it's something structural, that has to be dealt with at some point sooner or later.
Mm-hmm. Yeah, I have a case that I knew her when she was 16, and I thought she has endometriosis. I mentioned it to her mother, and the mom didn't really understand what that meant. Mm-hmm. And so no care was given, no follow-up to what I had assessed. And then fast forward 20 years and a miscarriage and 2 IVFs later because it wasn't treated when it should have been, unfortunately. I'm going to switch gears to progesterone. Endometriosis falls under the category of estrogen dominance conditions, right? Even though we're talking about it as undifferentiated embryological tissue, it does respond to hormones, and in an estrogen dominant population like we are, does it kind of beg the question that should we be Should we be giving these patients extra progesterone? Dr. Beck explained why we don't want to do that, but I'm just wondering from the surgeon's perspective.
I don't think that, supplementation of any sort is really appropriate. I think the general use, for example, of like combination oral contraceptives in patients with endometriosis is helpful and is FDA approved for only one thing, which is decreased menstrual pain during your period. Why? Because the pill stops you from ovulating. So if you're not ovulating, then you're not going through the hormonal ups and downs every month. In which case you're not stimulating these lesions as much as in the sense of them causing you more symptoms. They're still there and they're still progressing. It's just diminishing some of the symptoms. And it's the same, for example, like drugs like Lupron and Orilissa. One is a GnRH agonist, one's a GnRH antagonist, which ultimately do the same thing. It shuts your ovaries down and puts you into a chemically induced menopause, which is not what the pill does. The pill just basically fools your brain into basically thinking that you're pregnant, so you're not ovulating. They're all Band-Aids. They at best will diminish some of the pain symptoms, but everything is still marching forward. It's, the best analogy is in California, you don't have it as much, but if you live in more varied climates, like on the East Coast, your front lawn looks beautiful in spring, summer, and beginning of fall, and it's lush and green. And then in the winter, it's kind of not so pretty and not so lush, but it's still there. And then spring comes and it comes back. So the winter is Lupron and the rest of the year
analogy.
So it's not getting rid of it, because some I have patients that come to me telling me that their doctor told them that that these medications can melt away their endometriosis. It's not only false, but it's cruel to mislead people like that. Although some people probably are convinced that that's true, but it's not. And there's no conservative means to treat it.
Yeah, no magic pill.
There's no magic pill. And granted, when you go through menopause, it may be less metabolically active, but it's still there. Do I see postmenopausal patients who still have issues? I do. And I've operated on postmenopausal patients because you don't even have to have active, big, plump, red, purple lesions. You can have deep fibrotic endometriosis that's been there for 40 or 50 years that's now caused this rubbery, hard, puckered nodule that's impinging on nerves. It could obstruct vital structures like a ureter. So I've had patients who have basically had a dead kidney that they were unaware of because the endo basically blocked off their ureter they had and basically killed the kidney. And so you don't want to wait until that happens. You don't want to wait until you have a deeply invasive lesion in your bladder that requires me to take out half your bladder and have the urologist have to reimplant your ureters into your bladder. It takes a relatively uncomplicated surgery and makes it into a massively complicated, multi-specialty surgeon-involved kind of case.
Having been one of your postmenopausal cases, I am just so glad that you were willing to, or that you had the experience to work on my pelvis and that area behind the uterus,
right,
because we didn't have the technology for that in 2005. So using the robot arm to move it out of the way to clear whatever mess was back there.
Exposure is key. It's not necessarily just the laparoscopic or robotic equipment. It's the equipment, very basic equipment that we use to move or manipulate the uterus to be able to see behind it. So if you don't look, you're not going to find something. Mm-hmm. So like doing, what we call in our profession, the peek and shriek surgery, where you look in, you're like, either, I don't know how to treat that, or you look in there and you're like not really looking everywhere and then telling the patient that everything looks fine. Mm-hmm. Or patients, I've had more than my share of patients who are like, I had surgery 6 months ago, and they said I didn't have much going on, or I had 2 little lesions, and they took it out, and I go in there, I put the camera in, and I'm like, and there's like 16 implants, and they didn't even look behind the uterus, and there's a rectal nodule and lesions in the pelvic sidewalls and compressing the ureters, and you're like, where were they looking? So you have to be a good detective.
My surgeon said he saw it back there, but he wasn't able to get to it. And I don't know,
that's usually because they weren't comfortable
or
getting
the rest
to
of the surgery, getting the 200 adhesions off my left ovary took longer than he had. I don't know, but I know that after that surgery, I didn't have pain in the front of the uterus anymore. It was all in the back and in my sacrum and down my legs.
Right.
And then after the vaccines, I felt that inflammation had been triggered and that area was awakened.
Right. Yeah, and inflammation is definitely a big part of it. And some people are more sensitive to, inflammatory triggers. And I think that in the case of endometriosis, that's definitely the case. And that's why kind of cleaning up someone's environment, so to speak, is really key. Implementing a lifestyle that is as devoid of products that are filled with preservatives and other toxins and chemicals is crucial. Consuming a healthier diet,
more real food.
Yeah, I would probably say 9.9 out of 10 patients who just implement that as a first step already start feeling better.
Removing the causes.
Yeah. From an inflammatory standpoint, I see it in many times in my patients where I've seen the before picture because I saw them, when they first walked into my office, and then I see them, even 6 weeks after surgery, and even their facial puffiness is gone. And then you ask them, like, yeah, I used to I didn't feel right. Like, like they were puffy and bloated and swollen ankles and, puffy eyes. And it's mostly, if not totally gone. It's a combination of all those different tactics of cleaning up your environment and surgery and all the other elements of treating it. And that you put them back on course to be their best self.
Right. Well, you certainly did that for me. There's an interview about us talking further inside the SEED endometriosis course where you're really explaining endometriosis and helping patients make a decision whether or not to have surgery. So I appreciate all that you do for these women. Is there anything else you would like to say before we wrap up?
What's key is knowledge, information, and awareness. And I think people really need to avail themselves of all the knowledge that's out there and to have to be armed with the right information to make the best decisions for themselves so that you don't pursue like a piecemeal approach to treating a problem.
That's very long and slowly
correct.
unfolding.
Because it's in study after study, it's shown that the best long-term results are in patients who have excision surgery as their first surgery. When you have patients who have ablation surgeries, 1 and 2 and 3 and 5 and 10, like with each ablation surgery, they diminish their likelihood of having a thorough, proper excision surgery because of all the distortion of anatomy and it creates a more difficult environment to be able to address and fully remove everything.
Yeah. Good insights. Thank you so much.
My pleasure. Thank you for having me.
Yeah. Speaking of information, where can patients find you?
So my office is here in Los Angeles. It's actually in the office buildings behind Cedars-Sinai Hospital, 8635 West 3rd Street and Suite 880. And
do you have a website?
I do have a website, lagyndoc.com, lagyndoc. And I also have an Instagram and Facebook and all the social media where we post a lot of informative posts almost daily. And any studies that come out, like that celiac disease study we posted this week.
I enjoy your posts because you acknowledge the emotional component to, and that you're a man and that you care and that you see these things happening in women. It really comes through in your post.
But I think that's important because you're treating a person, and this is what I tell patients all the time. I don't look at patients as a pelvis. Like I don't have tunnel vision. It's someone comes and you see from the look on their face and the emotion and the sense of urgency and desperation that they have, and you really need to treat the entire individual, and regardless of what condition it is, because it's something you may understand what they're going through, but they don't. Mm-hmm. And it's very validating when you acknowledge that, and when you explain what they're experiencing, so they actually understand it and they see the causality and the linkage between things. Whereas before, like you said, people are told it's in your head. Like, there's no reason why, it's your anxiety. I have patients who are on sleep medication, anxiety medication, antidepressants, and they either get completely off of everything or they're on almost nothing once they actually address the actual problem.
Root issue.
Exactly.